So I can't think of a better suited person to come today to speak to us on this topic. So please join me in welcoming Dr. Ballen.
Well, thanks very much, Kathy, for that nice introduction and for inviting me today. So, as I mentioned, we're going to talk about alternative donor transplant. This is very informal, so please, feel free to interrupt if you have any questions or comments. But I'm going to give a little bit of background for the non-transplant people in the room on both autologous and allogeneic transplant, talk about some of the patient care issues that we face, and then end by talking about where we are with what we call alternative donor transplant for people that don't have donors in their family, and some of the novel treatments and future directions that we're working on. So our objectives are to explain reasons why a suitable match-related or unrelatable stem cell donor may be difficult to find for a given transplant recipient, to list the advantages of each of the alternative stem cell sources, umbilical cord blood and haploidentical stem cells, compare differences in transplant-related morbidity and mortality associated with these different stem cell sources. So for an autologous transplant, so a transplant using someone's own stem cells, the idea is that if you give more chemo, that's going to be better. So it really works for patients whose diseases are chemotherapy sensitive, primarily myeloma, lymphoma, Hodgkin's disease, occasionally things like germ cell tumor in children, neuroblastoma. But it's not going to be effective for things like pancreatic cancer, gastric cancer, which are diseases that are generally not sensitive to traditional chemotherapy. With modern techniques, this is considered a very safe procedure with about a 0 to 2% transplant-related mortality. And we do this procedure up to patients age 75 who have a good organ function and good performance status. So if they're fit and they're active, then they might be eligible for transplant. So basically the first week they come into the hospital, they get high-dose melphalan if they have myeloma. And if they have lymphoma, we use a conditioning regimen of R-beam, so that's Rituxan, BCNU, etoposide, cytarabine, and melphalan. The chemo is pretty tough in terms of GI side effects and also myelosuppressive. On the day of transplant, their previously collected autologous stem cells are infused intravenously. Then their counts fall and hit their nadir. During that period of time, they're getting blood transfusions, IV antibiotics for fever and neutropenia. And I'll just put a plug in that the key to survival in these patients is to jump really quickly on the IV antibiotics. And even if there's not a fever, but there's a change in the clinical condition of the patient, they're slightly hypotensive, their mental status has changed, they're having chills, they just don't seem right, then sometimes that's an indication of impending sepsis. And you can save someone's life by culturing them and starting antibiotics immediately rather than waiting for a fever 6 or 8 hours later. Then count recovery for the auto patients is usually around day 8 to 10 after transplant, and pretty soon after that, they're able to be discharged. And probably over the next several months, we're going to be looking at whether we can move some of this care into the outpatient setting. Now, these are the risks of autologous stem cell transplant, and of course this fits into what they get for prophylaxis. So early after transplant, in terms of viral infections, would be HSV, and then later on zoster. Fungal infections would be Candida, pneumocystis can be a concern, bacterial infections when they're neutropenic, pulmonary toxicity, but the biggest cause of death after autotransplant is relapse of the primary disease. Now for allotransplants, for those patients who have acute leukemia, they have myelodysplasia or myeloproliferative neoplasm like myelofibrosis, the therapeutic rationale is twofold. One is the conditioning regimen to kill off any remaining cancer cells, but we're also giving a new immune system, and that's where this graft versus leukemia or graft versus malignancy effect is important. So there's something helpful about getting someone else's immune system to help fight the leukemia. And in fact, studies have shown that patients who have a little bit of graft versus host disease have better survival than if you have no immune complications. But there's a cost to the patient of this in terms of toxicity. So the transplant-related mortality, 0 to 2% with auto, is 10 to 20% with the allogeneic transplant. And that can often be from infection, from poor immune recovery, or graft versus host disease from attack of the health host tissue by the donor immune cells, and organ damage from the chemotherapy or radiation. And there's also significant issues in terms of quality of life for long-term survivors of allo transplant. And that's a big issue now in our field as we're cured more and more patients. So we've overcome many prior obstacles. One is that we have a donor for everyone, and I'll explain why that is. And also with better supportive care, nursing care, and the use of reduced intensity chemotherapy, we're able to extend the age up to age 75 for these patients by using a lower intensity conditioning regimen. Now for the allo transplant, the patient comes in the first week. If they're young and fit, they'll also receive a myeloablative kind of high-test chemo, which often is busulfan and Cytoxan, or for some patients might be Cytoxan and total body irradiation. And if they're older or they have other medical problems, then we would use a reduced intensity regimen. And in our program, that's most often busulfan and fludarabine. And recently, we've made a switch to the intravenous form of busulfan. On day 0, they get infused their allogeneic stem cells, and that could be from a brother or sister, from a volunteer donor, from a haploidentical, or from cord blood. Their counts fall. And the difference here between the auto is, in addition to the counts falling, they're also getting medicines to prevent graft versus host disease, usually tacrolimus or tacrolimus and methotrexate, and that has toxicity itself and also increases the risk of infection. So these patients are usually in the hospital about a month, and the transplant course can be more complex. And then when we see them as an outpatient, sometimes we're seeing them daily in the infusion unit. So this is the problem. These are the risks of allotransplant. You name it, these patients have it. So from infections, viral infections, we're seeing BK, CMV, HSV, zoster, respiratory and enteric viruses, RSV. We see pneumocystis pneumonia. We can see aspergillus and other molds, particularly if patients are on steroids for graft versus host disease. Encapsulated bacteria can occur late after transplant. That's one of the reasons why everyone gets vaccinated. And on the non-infectious side, we have mucositis, we have acute and chronic graft versus host disease, graft failure, red cell aplasia from an ABO mismatch, post-transplant lymphoma, veno-occlusive disease, bronchiolitis obliterans. So there's numerous early and late side effects for these patients. So now I just want to kind of take you through a couple of patients that we've treated recently. So this patient is a 59-year-old musician. He noted enlargement of neck nodes. A CAT scan confirmed this. The biopsy showed mantle cell lymphoma with a characteristic cyclin D1 staining. And I want to mention actually mantle cell lymphoma, the genetic basis of this disease was actually discovered here at UVA by Mike Williams. And so mantle cell lymphoma is a mature B-cell non-Hodgkin's lymphoma. The median age is in the 60s. About 70% of patients have advanced stage disease at the time of diagnosis. For those patients that do have early stage disease, they can be treated with chemotherapy or chemotherapy and radiation. Older patients might be treated with a kind of a lower intensity regimen of bendamustine and Rituxan. And for the younger patients that have more advanced disease, we would use chemotherapy and an autologous transplant. So this is a couple of studies that have looked at autologous transplant for mantle cell lymphoma. This is a large study from Scandinavia, which showed a survival advantage to auto transplant versus chemotherapy. And in the CIBMTR, which is our international registry, there was an advantage to auto transplant doing it early in the course of disease rather than later. Interestingly, there was no benefit to allo transplant in these patients, probably because there's an increased risk of toxicity with the allo transplant. And recently we're looking at maintenance therapy. So traditionally you had your auto transplant and kind of you were done with treatment. Now we're looking at ways to prevent relapse by giving some low-dose chemotherapy treatments after transplant. So this would be rituximab, which has been shown to prolong survival. This was a phase 3 trial by the French group that was presented at our hematology meetings and showed if you got 4 cycles of chemotherapy, you underwent autologous transplant, and then if you were randomized to Rituxan maintenance, Your survival at 4 years, progression-free survival, was 80% for maintenance versus 65% for no maintenance. And 90% of patients were alive at 4 years after transplant. So this suggests a survival advantage for Rituxan maintenance. Whether these patients are cured, what happens at 10, 15, 20 years out, we just don't know. But suggests even early on we're having some benefit for this. So that's what we recommend now. So getting back to our patient, he was actually treated at another center for his initial chemotherapy, referred here for transplant. He had some kidney dysfunction and therefore didn't receive his initial cytarabine, received 2 cycles of standard chemo, and then went on to receive the cytarabine-based chemotherapy. Auto transplant was complicated by hypotension, atrial fibrillation, had a few days in the MICU, but he's now 6 weeks after transplant and doing very well and back playing the guitar. So we think that he's going to do well. Now I want to move on to allotransplant. So this is a 36-year-old man. He's a builder, presented with fatigue, shortness of breath, and night sweats. White count at 98,000, and a bone marrow showed acute myeloid leukemia. And he had a genetic mutation on the FLT3 mutation, and he is no match-related or volunteer donor. So he was treated with intensive induction chemotherapy, what we call 3 and 7, which is daunorubicin and cytarabine. And the CR rate for that is about 70 to 80%. So most patients go into remission, but the relapse rate is over 50%. And that's really the main problem in treating patients with AML. This FLT3 tyrosine kinase inhibitor is associated with about 30% of adults with AML and is associated with a high relapse rate. So in terms of allotransplant for AML, we usually recommend allotransplant when the patients are in remission, so after they've received their initial induction, and that could be based if we think they're a high risk of relapse. So that could be based on their chromosome, their molecular markers, or age, are all prognostic factors for relapse. And again, if they're young, they would get a full dose, what we call myeloablative chemo, usually busulfan and Cytoxan or busulfan and radiation. If they're older or they have other medical problems, they would get a less intensive conditioning. And as I'm going to talk about in a few minutes, in 2017, almost everyone can find a donor. So options for graft sources, if each sibling has a 1 in 4 chance of matching the patient, 25%, that's just based on genetics. So for most families in the U.S., about 30% will have a match donor in their family, a brother or sister that's a complete match. It's interesting that if you live in Pakistan, your chance of finding a donor is 80%. Anyone want to take a stab at why that might be? Big families, and intermarriage, marrying your cousin, part of the culture, so more likely to find a match in the family. So for most people in the U.S. and other developed countries of small size families, we're looking at other options. So the most options that people would look at would be to look for an unrelated donor in the registry. So this is the Be the Match National Merit Donor Program. Anyone on the registry? Great, great. So as you know, right now it's just a cheek swab. And the registry is particularly interested in young donors. They seem to be better than young stem cells, seem to be better than older ones. So there's over 25 million volunteer donors in the registry, but the composition of the registry, despite intensive recruiting efforts, is still predominantly white. The registry actually started in England and now it's in Minnesota. So if you are of white and of Northern European background, like Anglican background, England, Germany, you have about a 67% chance of finding a donor in the registry. If you're African American, you have a 23% chance. So it's definitely dependent on your racial and ethnic group. And for Black patients, it's not just there are not enough Black donors in the registry, but there's a lot of genetic heterogeneity from Africa in the African American population that makes it more difficult to find match donors. So for those patients, we are looking at what we call alternative graft sources, which I sort of hate that name, but that's what's stuck. And that can either be blood from the umbilical cord, what we call a haploidentical or a half match, or an unrelated donor that's not a perfect match, what we call a 7 out of 8 match-related donor, or a mismatched MUD. So which of the following statements about stem cell graft sources is true? A, African Americans have a better chance of finding a matched unrelated donor than Northern European whites. B, the chance of a sibling donor being matched to the patient is about 30%. 3, most patients receive stem cells from a sibling. And D, none of the above are true. Anyone want to take a stab at that? B, yes. Yes, so B is correct. The chance of a sibling donor being a match to the patient in the U.S. And Western Europe is about 30%. Okay, so now we're going to talk about cord blood, which is one option for patients that don't have a donor in their family or can't find a donor in the registry. So cord blood is collected at the birth from term babies, no fetal research. There's no risk to the mother or the baby. And it's usually something that's normally just thrown out. This would be thrown out with the placenta with the afterbirth. This was initially studied in children and then more recently extended to adults. And about 40,000 cord blood transplants have been performed worldwide, and about 25,000 patients have been cured. And again, these are patients who most likely would have died because they had no other donor option at the time. About 700,000 cord blood units have been donated to public storage banks both in the U.S. and throughout the world, and that represents 43 banks in 28 different countries. Now, I got interested in cord blood based on, do we have a pointer? But anyway, this guy who's second from the right, Peter Quesenberry, who's actually former head of Hem/Onc here at UVA. He went up to Massachusetts and despite the fact that I had no experience at all, recruited me and said, Karen, would you like to go throughout Massachusetts and enroll pregnant women? I think cord blood will be big. So I said, sure. And hence we started. Now, also in this picture, there might be someone you recognize. In the second row, a faculty member here in Hem/Onc. On the far right, you got it, a young Mike Williams. Okay, so I don't know if anyone's been contacted, if you have friends who are pregnant or pregnant yourself, about whether you should donate your cord blood into a public storage bank or save it for private use. This is kind of a big issue, particularly in affluent areas in the country. In general, we don't recommend private banking for the following reasons. If cord blood collected, let's say a baby at the age of 2 develops leukemia, probably that cord blood at birth is containing leukemia progenitor cells. That's actually been shown in some studies, and so you wouldn't want to use that to give it to a child with leukemia. That child would be better served by getting an allograft of transplant from someone else. And to be honest, we have no idea how long these really last. So if you save your baby's cord blood thinking in 50 years when my baby, let's say, has breast cancer, will it be useful for that? We have no idea. For that reason, this is the American Society of Blood and Marrow Transplant, American Academy of Pediatrics, have all recommended donate to a public bank. And just looking at the numbers, as I mentioned, about 700,000 cord blood units stored for public use, only about 5% used for transplant. That is a major factor, and it's at the beginning, the units were very small. We kind of found out the hard way that a lot of those units are not really good for transplant. Now the banks are collecting larger units that we think are better for our patients. About 4 million units have been stored for private use, and 0.02% have been used for transplant. So storing for private use is not likely to be used, and it's taking something out of the public domain and into the private domain. But nonetheless, that is a service that people can buy, usually for an upfront fee and then a yearly storage fee. I will mention one thing is that recently Duke just published a couple of papers on using autologous cord blood both for cerebral palsy and autism. And if those studies take off, obviously those diseases are very important worldwide, and there possibly could be use for autologous cord blood in that situation, or maybe use for the many cord blood units that are small that we can't use for traditional transplant. So I think it's a moving target, and we'll have to really reassess this as the field advances. Now, I think it's interesting to look at how other countries deal with this. So in France and Italy, which of course have national healthcare systems, private cord blood banking is illegal. So it's not permitted under law. But I'm sorry, there's a fly here. Both of those countries have an extensive public cord blood banks that most of their deliveries are done by nurse midwives. And they kind of have an opt-out policy, so the mother can opt out, but they don't need to sign the 30-page consent form that we do here. So different kind of IRB and other standards. In Spain, they wanted to do the same thing, but the Crown Prince wanted to bank his baby's cord blood. European thing. So private cord blood banking is allowed under certain circumstances, but they also have very large public cord blood banks. And in fact, for instance, when I was in Boston, we have a large Italian-American population. We would get a lot of cord blood units from Europe, from Italy. In Switzerland, they have kind of the hybrid bank, which is kind of an interesting idea, where a family may donate, they pay an upfront fee, and save it for their own family, but it's also listed on the registry, and if it could be used to help someone else, the family is contacted, and if they give permission to do this, then they get their money back. So that's kind of an interesting idea about how to fund public cord blood bank, because public cord blood banks are having a very tough time financially with all the new regulatory issues. But in the U.S., that would not work because private cord blood is banked on a much different quality standards than public cord blood, and they cannot cross over in the U.S. England, Branson's, the guy who started Virgin Atlantic, has the idea of sort of saving cord bloods in aliquot, so you take like a little for private and public use, but the cell dose in cord blood is so tight anyway that hasn't really taken off. And then in a lot of emerging economies, there is a growth of private cord blood bank fueled by American industry. The FDA has kind of tried to crack down on this because some of the advertising it could be misleading. So what are some advantages of cord blood over a traditional bone marrow peripheral blood stem cell transplant? So there's no risk to the mother or baby, as I mentioned. I just came back from a meeting at the donor program, and one of the issues now is delayed cord clamping, which is kind of a new thing in obstetrics, and that may alter how much is collected from the cord blood, but we've always said, deliver the baby, do what you need to do for the baby, and then afterwards, deal with the cord blood. It is readily available, and that's really important because some of these patients with leukemia, if you're waiting for an unrelated donor and the unrelated donor's on vacation or this or that, or they have to get retested, that could be a couple of months. Whereas with the cord blood, you can get a call on Tuesday and the unit is at your doorstep on Thursday or Friday because all the testing is done up front. There appears to be less risk of graft versus host disease, and that's because immunologically the cells are more naive. And there's an opportunity to increase the size of the donor pool, particularly for minority donors. And because there's less risk of graft versus host disease, the cord unit and the patient do not have to be perfectly matched. And so that opens up a greater chance of finding a donor. And recently, the group in Seattle, and I'll show you this data in a few minutes, showed that there may be a lower relapse rate. And that's particularly true for patients with leukemia who may have minimal residual disease that we can't see but we think is there. But there's some critical concerns with cord blood. It's a one-time donation. Obviously, you can't go back to the baby and ask for more. There appears to be a higher risk of infection in transplant patients who get cord blood transplants, probably related to the fact that their immune cells are less. The cost is considerable, and this is a huge issue. So it's about $40,000 for a cord blood unit. So if we're doing a double cord blood transplant, which we're doing on most adults in the U.S., that's $80,000 before the patient actually sets foot into the hospital. Fortunately, this has been covered by most insurance companies, but from a kind of health economics, resource allocation standpoint, that is an issue, especially now as we're discovering some maybe more cost-effective ways to do the transplant. And the other thing is that we found that the cell dose is an important factor for engraftment, for getting the cells back and for survival. And so this cell dose, about 3.7 times 10 to the 7, so all done per kilo, is important. But the average unit that's banked would only cover about a 40-kilogram person, so either a child or a very small adult. The other thing is that we're heavy in the U.S. As I said, we are fat. So we're about 10 kilograms heavier than in Europe and about 15 kilograms heavier than Asia on average. And that is one reason why we use double cord blood transplant in the States, and the Japanese are using single cord blood transplant. And you can see that's a big economic issue as well. So to get around some of these issues of the cell dose and could you use one unit, suppose you expanded it in the laboratory with cytokines like GCSF and other cytokines, that's being looked at, and also homing, ways to actually get the cord blood unit right where it needs to be to try to get the cell counts up faster, using two cord bloods together. Looking at better collection and banking techniques so that there's more cells in each cord unit. Strategies to reduce infection and to pick the best cord blood unit, and then can we use it in combination with other transplant sources, which the group in Spain is doing. So this is kind of a much younger me, and we're sending out one of the first cord bloods, this is up in Massachusetts, to a patient in Australia with leukemia. And so the cord blood goes in the dry, it's stored in liquid nitrogen, travels in a dry shipper. And when we first started, we actually had a personal carrier that came with each cord blood unit. You'd have to buy 2 first-class tickets, one for the courier and one for the cord unit, because it wouldn't fit into coach. And now these all go by like a world carrier service, but they're at the transplant center, and there's a temperature gauge to make sure the unit hasn't thawed before the patient starts their conditioning regimen. So there's a couple of things that we learned early on. As I mentioned, no risk to the mother or baby. Umbilical cord can be readily available. Interestingly, bigger babies make better cord blood donors, and also first babies, maybe because more cytokines are released from the stress of the first labor. Sort of an unfortunate fact is that the CD34 count, the stem cell count of cord blood, is lower in black than in white patients, and this is true independent of socioeconomic status or zip codes. And so more resources have to be put into collecting adequate cord blood units for black patients. Cell dose is important for outcomes, and that the cord blood does not need to be completely matched with the recipient. So this is kind of what the patient experiences, the regimen. Patient comes into the hospital a week before the transplant, day -8. They get fludarabine. They get melphalan. The little bunny rabbit is the rabbit ATG thymoglobulin. A few days before transplant, they get GVH prophylaxis with tacrolimus and sirolimus. And on the day of transplant, 1 unit is thawed, washed in the lab, given to the patient. A few hours later, the 2nd unit is thawed, washed, and given to the patient. And one of the things that we found is that the chance of graft versus host disease is extremely low with cord blood unit and our approach, which used the ATG and also sirolimus and tacrolimus. So less than 10% incidence of acute graft versus host disease. That has implications not only for mortality, but also for quality of life issues for the patient. But we did see some other problems: infections, viral and fungal infections, CMV reactivation, including really bad CMV, CMV colitis, HHV6 encephalitis. We saw second cancers, including EBV lymphomas, and once we cut back the dose of the rabbit ATG, those went away. A kind of an interesting syndrome of cord colitis associated with increased diarrhea that could be treated actually with Flagyl and Cipro, and a very low rate of relapse. And this study just looks at the T-cell recovery after cord blood transplant. So the cord blood is the sort of dark line, the stars are normal controls, and the pink is matched unrelated donor. So if you just look at the top right there on the CD4 cells, you can see early after transplant, cord lags behind. There's poor immune recovery. But by a year after transplant, patients are in good shape, that their immune recovery has come up. And that kind of mirrors what we see clinically. The first kind of 9 to 12 months with these patients is tough going. In other words, lots of admissions, problems, infections, but once they get past that year point, usually it's smooth sailing. And as I mentioned, we're looking at different strategies to try to improve results. So one thing that we worked on when I was in Boston was looking at prostaglandin, which you could incubate the cord blood cells to, and improves homing into the bone marrow. And we did show that engraftment was improved, but there was not a big difference in survival. This is one I like. The group in Genoa uses a direct intramural injection. So instead of giving the cord blood intravenously, they actually, through a bone marrow needle, actually inject right into the iliac crest under conscious sedation. It hasn't really taken off here in the States, but that might be another way of doing it. And then there are some other novel approaches to improve. And also looking at ex vivo expansion, so taking the cord blood unit, expanding in the laboratory with cytokines. And I'd say the one that's furthest along is this third one by Mitch Horowitz at Duke. That's now in a randomized trial using a nicotinamide-based expansion system. And they are going for an FDA license, so that could be the first license expansion if that is positive. So how does cord blood compare with other types of transplant? So this is a study that we looked at comparing to related donors and matched unrelated donors, all of whom received reduced intensity conditioning regimen. And what we found is that survival was the same, regardless of where you got your donor from, because it's true that cord blood had a higher risk of infection and more upfront complications, but the risk of relapse and chronic forms of graft versus host disease were lower. And with the unrelated donors, the risk of graft versus host disease was higher. And with a related donor, because there's less graft versus host, there's a higher risk of relapse. So at the end of the day here, the results are about the same. But you can see that we're only really helping about 35 to 40% of patients. So there's still room for improvement regardless of the graft source. But for patients, they shouldn't be upset if they don't have a donor in their family, because almost all studies have shown that whether you use a family donor or a donor from the registry of cord blood, the results are about the same. So, question number 2, which of the following are advantages of umbilical cord blood versus bone marrow and peripheral blood stem cells? A, cord blood cells are more readily available. B, larger size of donor pool, especially minority donors. C, lower risk of graft versus host disease. Or D, all of the above. D, that is correct. Yep, you got it. So now I want to move on to haploidentical transplant, which is kind of the new kid on the block. So a haplotransplant is a half-match transplant. So just based on genetics, your parents and your children will be a half match to you, and 50% of your brothers and sisters. So most, but not all patients will have a haplodonor in their family. The haplotransplants have been shown to have a decreased risk of infection and upfront cost, but a higher risk of relapse. And then I'll show you there's a phase 2 study that showed that survival was similar. And this is now part of a large national phase 3 study that's randomizing patients between double cord blood versus haplomarrow. This is a very important study to complete nationwide. Accrual has been tough because it's hard to randomize people between 2 completely different transplants, so we are still working on it. But this is the data from these kind of 2 phase 2 studies. So the studies were completely separate but had similar eligibility. And basically on the left side is cord and on the right is haplo. So with the double cord, what we see is that the transplant-related mortality, the chance of dying in the first year after transplant, not from relapse, was 24%, and it was only 7% for haplo. But the relapse rate was a lot higher for haplo, so at the end of the year, survival is the same. And the reason for doing the randomized study is obviously to randomize the patients, to have a longer follow-up. We're also looking at quality of life and costs, not just like insurance costs, but like costs to the patient in terms of parking, things like that that are not covered by insurance. There have been many retrospective studies comparing haplotransplant to other types of transplant like matched unrelated donor. This is a study in lymphoma showing that survival is the same. Now, I mentioned about patients with minimal residual disease. So these are patients that have leukemia. Their bone marrow shows no obvious leukemia, but when we look at molecular techniques, we can see that there's a small amount of disease that we can't see minimal residual disease. This is kind of a hot field in oncology now, trying to pick out these patients and maybe have them go to more aggressive treatments. So this looked at patients who have minimal residual disease. The black line is cord. The blue is HLA matched, and the red is HLA mismatched. And what we showed is that if you have minimal residual disease, your survival is better after cord blood transplant comparing to the mismatch. For the matched, it was not statistically significant. And the relapse rate, again, was less for cord blood compared to either HLA match or HLA mismatch, so that there is a decreased relapse rate for using cord blood versus other graft sources for leukemia patients with minimal residual disease. And maybe those are patients who should be getting cord blood transplants, and maybe there's another subset of patients that should be getting haplo or another graft source, and hopefully at some point we'll be smart enough to figure that out. These are also some other studies that support this concept that there's a better graft versus leukemia effect in cord blood transplant than other transplants. So again, all showing a decreased relapse rate for cord versus other graft sources. So question number 3, true or false, haploidentical transplants have a higher risk of relapse than cord blood. Yes, that is correct. Now, what about cost? Obviously, this is a big issue now. Transplants are expensive. Anybody have an idea how much it costs to do an allo transplant on someone, or what the charges are? Take a guess. So what we get reimbursed by the insurance company is about $250,000. And most of our patients are on a case rate basis. So that means if the patient does well and we manage the patient cost effectively, they're out of the hospital and we think they're at the hospital makes money. If we have a patient that's been in the hospital about 3 months, like some of our recent friends who both are doing very well, the hospital obviously loses money. So this is data from our transplant registry. The transplant registry does not accept any cost data because, how could you compare costs between like Charlottesville, Virginia and New York and, Topeka, Kansas, and, everything is different and it's different payers and things like that. So what the registry does is it looks at length of stay, which is the biggest driver of cost. Your drugs are also very expensive, but actually the biggest driver of cost is the amount of time the patient's in the hospital. So if you just look at the length of stay and you say, okay, well, someone's out of the hospital in 10 days, that is misleading because suppose they die in the first 10 days, they're out of the hospital, but obviously not the outcome that we want. So when we look at this, we're looking at days alive and out of the hospital in the first 100 days after transplant. So it's better, obviously, to have more days alive and out of the hospital. And what this shows is the dark blue is cord blood, that if you receive a cord blood transplant, you will have fewer days alive and out of the hospital in the first 100 days after transplant compared to other graft sources. Also, if you're Black, you will have fewer days alive and out of the hospital. So race was also significant. So this just looks at early costs, and based on this, does not look favorable for cord blood. We do want to look at later costs as well because relapse obviously has a cost, or chronic forms of graft versus host disease. They're just much harder to capture because that data is not currently captured in our transplant registries. And now I just want to end, this affects transplant, but it's looking at some new drugs recently approved for leukemia. So one is midostaurin, which is a non-specific FLT3 inhibitor, showed an improved survival in a phase 3 study, and recently approved for the treatment of FLT3 positive AML in addition to standard chemo with a significant advantage in median survival. This is the data from the New England Journal showing an improvement in survival with midostaurin. Other thing that we've looked at is post-transplant maintenance in these patients who are FLT3 positive. And if they receive sorafenib, not approved, of course, for AML, but approved for other cancers, post-transplant, their survival was pretty good, was at 81%. And you can see the blue line is the no sorafenib arm, not randomized, showing that there may be an improvement in survival for patients to get post-transplant maintenance. So getting back to this patient that I mentioned, the young gentleman with AML, is working to achieve remission induction. We have identified cord blood and haplodonors, and he has consented for the randomized study with the plan for post-transplant sorafenib. So what about the future? This is just a guess, but I think autologous transplant will remain a standard tool for myeloma and lymphoma. I think cost and quality of life are going to be very important endpoints going forward. For myeloma, of course, there's many new drugs, and how transplant fits in there, I think, will be key. I think autotransplant will be combined with novel therapies given as maintenance, so given after transplant. And we're actually starting a study here shortly looking at pomalidomide and ixazomib, 2 new drugs for myeloma, as maintenance. I think we're also going to see use in non-malignant diseases like autoimmune disease. There's a paper in press at the New England Journal looking at autotransplant for scleroderma, showing a survival advantage compared to Cytoxan. And perhaps patients with hemoglobinopathies, that there may also be an advantage to transplant or to use with gene therapy. Now, in allotransplant, I think we're going to see integration with some of the targeted agents like the FLT3 inhibitor, checkpoint inhibitors, which are now being used in some post-transplant situation. And obviously, we're very excited about the recent approval of CAR T cells and how that will fit into transplant, whether that will be a bridge to transplant for those patients with leukemia or lymphoma, substitute transplant in some cases, or perhaps used after transplant to reduce relapse. I think we'll have to see. We are seeing increasing use in patients with MDS and AML, especially in older fit patients. And I think we'll see an interest in maintenance approaches after transplant, especially if we can use minimal residual disease, if we can use molecular techniques to figure out who might benefit from this. And I think, as I mentioned, the alternative donor, I think there's a goal, almost a donor for every patient in 2017 if they're going to use cord blood, the haploidentical, or the mismatched unrelated. All retrospective data suggest comparable survival. Cost is going to be important. I think we'll see a growth of regenerative medicine with autoimmune, neurologic, and also cardiac diseases. And actually, what I'd like to see is, just like for breast cancer, there are computerized decision tools, based on the size of the tumor, molecular characteristics you can put in, and boom, out comes what to do. It would be great to have this for picking donors for patients. So you could put in their antibody screen, their disease, their age, the donor options, and out comes what to do, rather than sort of sitting at table on Tuesday morning and saying, we should do this, we should do that. And I think the donor source will no longer be a barrier to transplant, whereas 5 or 10 years ago, that was one of the major barriers. We obviously have other barriers in terms of access to transplant. Only about a quarter of the patients who could be cured by transplant actually come to a transplant center. And so we do have very important issues in terms of access, but not necessarily donor source. And finally, I'd like to thank the babies who on their first day of life gave the gift of life to someone else. Thank you very much. Happy to answer any questions. The registry is all international. It's international. But the places where there are big donor registries besides the U.S. are in Western Europe. Japan and China have their own registries, but they're not eager to export. That may be changing. There are some registries, for instance, in countries we don't have diplomatic relations with, that may be hard to get products out of, but except for those few countries, it's not a problem. And these go on both sides, go from the U.S. elsewhere and also into the U.S. Yes, absolutely. It's actually easier with cord because it's frozen and it's easier. Just it's a little bit more expensive to get a cord blood unit. Japan has a very large cord blood bank, and they have very good results. They actually don't do any unrelated donor transplants. And I think it's also because they're an island population, a lot of genetic homogeneity, and they're also smaller on average, so it's a little bit easier to do cord blood transplant there. But yes, both for cord blood and for adult volunteer donor. That's actually why the National Marrow Donor Program changed their name to Be the Match, because it's no longer marrow and it's no longer national. Other questions? Great. Well, thank you very much. Have a great weekend.